All right, team, let's get into it. For your ab site and your boards, there is literally no higher stakes scenario than septic shock. Seriously. This isn't just another topic. It's a full-on test of your entire surgical physiology knowledge base. So let's nail this, right here, right now.
You know the scene. It's always the same. It's the dead of night, the unit's quiet, and you're the senior resident on call. This is exactly when the first subtle signs of a catastrophe start to bubble to the surface.
And then, bam, the pager screams. Every single number on that screen is a big, flashing red light. This is not just a little hypotension. No, this is the start of a total systemic meltdown in your post-op patient. And what you do in the next few minutes, well, that's going to determine if they see the sun come up.
To get through this, you need a roadmap. So first, we'll define our enemy using the Sepsis 3 criteria. Then, we're going to dive inside the body city to really get a feel for the chaos at a cellular level. We'll break down the difference between warm and cold shock, master that critical hour 1 bundle, and then wrap up with the absolute #1 job we have as surgeons.
Okay, first things first, let's define the enemy. To crush this on your exam, you have to know the latest definitions like the back of your hand.
So what's really important here is why this change happened. For a long time, we all used SARS. But think about it. In a post-op patient, who isn't SARS positive just from the stress of surgery? It's a net that's just cast way too wide. Sepsis 3 is way smarter. It shifts the focus from just inflammation to what really truly matters: organ dysfunction.
Okay, if there is one thing you burn into your brain from this section, it's this official definition right here. The key phrase, the money phrase, is organ dysfunction. Without that, you've just got an infection. But for your exam and for your patient, it is not sepsis until those organs start taking a hit. So how do we measure that dysfunction? We use the SOFA score. You got to know these 6 systems cold. Now, you don't have to memorize this whole crazy table for the exam, but you absolutely need to know the rule of 2s. An acute jump of 2 points in the SOFA score, that equals about a 10% mortality risk. And listen, if you see a score over 11 in an SICU patient, that's a 5-alarm fire. We're talking mortality rates pushing 90%.
For a quick check at the bedside, we have Q-SOFA. You can remember it as HAT, hypotension, altered mentation, and tachypnea. But, and this is a huge board trap, Q-SOFA has terrible sensitivity. It only picks up patients who are already deep in trouble. That's why the new, high-yield thing, and where your boards are definitely going, is the shift to more sensitive systems like NEWS or MUSE. They're built to catch that subtle decline much earlier.
So what kicks a patient from sepsis up to full-blown septic shock? It's these 3 simple objective criteria. 1, you need pressors to keep that MAP at 65 or higher. 2, your lactate is stubbornly above 2. And 3, this whole mess keeps going even after you've pumped in adequate fluids. It's a totally objective, super testable definition.
And why is this all so important? Because of this number. The second your patient checks all those boxes for septic shock, their chance of dying in the hospital skyrockets to over 40%. This is, without a doubt, one of the deadliest things we manage in the ICU.
Okay, so we know what it is. But to really get why it's so lethal, we have to zoom in, way in. We're going from the monitor all the way down to the cellular level. I want you to think of the body as this complex city. And sepsis? Sepsis is a citywide riot breaking out on every block.
The absolute core problem in septic shock is this concept of hemodynamic incoherence. What does that mean? It means the big highways, the macro circulation, are completely cut off from the small neighborhood streets, the micro circulation. You can crank up the pressors and make the blood pressure number on the monitor look pretty, but down at the tissue level, the cells are literally suffocating.
On that macro level, sepsis is the textbook example of distributive shock. You've got inflammatory cytokines triggering this massive flood of nitric oxide, which just paralyzes the blood vessels. The pipes get huge, the SVR just plummets, and fluid leaks out everywhere. The heart, trying to be a hero, starts pumping like crazy to compensate, and that's what gives us that initial high-output warm shock state.
So what's controlling all this leakiness? It's this amazing structure right here, the endothelioglycocalyx. This is a super important concept. Think of it like a fragile, sugar-coated shag carpet that lines every single one of our blood vessels. It is the gatekeeper of vascular integrity.
And this is a perfect picture of what happens when that carpet gets totally shredded by inflammatory enzymes. The vessels get leaky, causing that massive third spacing you see at the bedside. The wall loses its negative charge, so cells start sticking to it.
forming tons of tiny microclots. And just like that, the local delivery streets of the body city are completely blocked. This, right here, is the soul of microcirculatory failure.
Now, all this cellular chaos, it doesn't just happen in a vacuum, right? It creates these really distinct pictures at the bedside. You have to be able to recognize the two main hemodynamic profiles of septic shock, so you know what you're up against. The classic adult presentation is what we call warm shock. This is that hyperdynamic, high-output state. The massive vasodilation makes the patient flushed, their skin is warm, and they have these bounding pulses. Cold shock is the total opposite. It's a low-output state, either because the heart itself is starting to fail or the patient is just completely decompensated. They're cool, clammy, with weak pulses. You see this a lot in kids and in really late-stage adult sepsis.
This table right here, this is your hemodynamic compass for the exam. I guarantee you will get a set of these numbers and be asked to name the shock state. So look at warm septic shock, high cardiac index, super low SVR. Now look all the way down at the bottom row, SVO2. This is the dead giveaway. It's the only major shock state where the mixed venous oxygen saturation is often high. And why is that? It's a tragic paradox. The oxygen gets delivered, but the cell's mitochondria are poisoned, and they just can't use it. The tissue is starving in a land of plenty.
Okay, now that we can diagnose it and we understand the why behind it, let's talk about the what. What do we actually do? This brings us to the most time-sensitive part of the whole algorithm, the hour 1 bundle. The clock starts ticking the second you even think sepsis. You have to memorize this, LCAFV. Measure your lactate, get your cultures, administer broad-spectrum antibiotics, start your fluid bullets, and get vasopressors going if they're still hypotensive. These 5 steps, done fast, save lives. It is literally that simple.
But here's the next level take for your exam. We're getting a lot smarter about fluids. First, you want to prefer balanced crystalloids like LR over normal saline to dodge that hyperchloremic acidosis. Second, that 30 milliliters per kilogram bolus, it's now a weak recommendation. The new thinking is, don't just dump in fluid. You need to use dynamic measures like a passive leg raise or stroke volume variation to see if the patient is actually going to respond to more volume.
And now, we're at the final, and, for us as surgeons, the single most important section. You can hang every bag of fluid and every presser in the hospital, but if you don't do this one thing, your patient is absolutely going to die.
So what's the answer? Your next call is to the operating room, period. Not to nephrology, not to pharmacy, to the OR. You have to remember this. Resuscitation is nothing but a bridge to the definitive therapy, and for surgeons, that therapy is source control. Everything else is just us buying time.
Look, mastering septic shock is all about knowing the definitions, understanding that deep physiology, and then acting with incredible speed and precision. If this deep dive helped you get a better grip on septic shock for your boards, make sure to like and subscribe for more critical surgical topics. Keep studying smart and be ready for that 2 a.m. page.